TopMedTalk.
Welcome to TopMedTalk. We are here day 3 of the World Congress of Anesthesiologists in Singapore. It is the 18th WCA and the first in over 8 years. So very exciting for everyone to be in person. It's been an absolutely fantastic meeting. The WFSA has done a wonderful job of bringing together and curating content. I think over 500 faculty members from around the world have been here over these last 3 or 4 days presenting. So very, very good. I'm Desiree Chappell. I'm your host, and I'm joined by 2 of my absolute favorite ladies in the world and professors of anesthesia, critical care, also internal medicine. We have Professor Denny Levett. Denny, thank you so much for joining us.
Thank you for inviting me, Desiree.
I think it's been a while, actually, since you've been on.
Yeah, I haven't done this for a while, I have to admit.
And then Professor BobbieJean Sweitzer. BobbieJean, welcome back.
It's great to see you, Desiree.
I know.
It's always a pleasure.
It is. We caught up last time at the ASA and had a fun talk there.
Seemed like yesterday.
It does.
Now been, 6 months?
Yeah, I know. Time flies and you're having fun. Well, it's been a great meeting so far. I know you guys both have been very busy. Denny, your thoughts on everything that you've seen over the last 3 days and people?
It's a great meeting to connect with people, not just those that you know, but from across the world. I think that's the nice feature of this conference. And I've been focusing mainly on the perioperative medicine track, but some really interesting talks about how can you evaluate patients, particularly in low middle income countries where they don't really have access to the resources we do here. And the challenges of preparing patients for surgery, particularly with the increasing age and comorbidity of our patient population. So it's been really interesting to connect and to listen to other people's experiences.
Yeah, absolutely. BobbieJean, what about you?
Yes, it resonates when you say about age and frailty. I've seen so many presentations here. I think every country, such a broad swath of countries are dealing with this issue.
Yeah, lots to be learned, but a lot of good sharing and probably some things that speak to you and some things that you're like, wow, I hadn't thought of that maybe.
Yeah, I think there's a really striking statistic actually from the World Health Organization I saw reasonably recently. Don't quote me exactly which report it was in, but for the first time in the world, there are more countries that are faced with a problem of obesity rather than malnutrition in terms of health behavior as one of their bigger health challenges. So just really interesting. So this is a problem that's facing us all across the world. And one of the problems with that is that a healthy diet in many countries is actually more expensive than an unhealthy diet. So these new ultra-processed foods, which do seem to drive obesity, are often cheaper. So difficult for people to get access to healthy eating. So I think it's really interesting.
Interesting when you use the word malnutrition. I think in the past, we've always thought of malnutrition as being undernutrition.
Yep.
But it's malnutrition. So I think it's also unhealthy diet can end up in obesity as well as an unhealthy diet that you are undernourished with, right?
Yeah.
Both malnutrition, but in a very different way.
Yeah, absolutely.
Yeah. So many people are living in food deserts. Is that a term that is common that you've heard? I mean, the U.S., that's what we say, rural America, not even rural America. I mean, urban areas, too, live in complete food deserts where they have no access to fresh food.
Yes, I've heard the term used, I think, slightly less common in the UK, but it is clear that the problem is that access to a healthy diet is expensive. That's one of the things. Eating out is culturally much more common in the States than it is in Europe, and your eating out is remarkably cheaper than cooking for yourself, whereas the other way around in Europe. So I think it's driven that slightly less, but the access to healthy foods when you do eat out is difficult.
Yeah.
Which reminds me of my food tour that I took a couple of days ago here, where the guy who led the tour said that Singaporeans almost never cook for themselves.
Yeah. I said the same thing.
Eat out. And they may get the food and bring it home. In fact, the common thing is to remark on how clean someone's kitchen is because they never use it. Yeah, I was surprised to hear that.
And there's no fresh food. There's no agriculture here in Singapore. Every single thing, even the fish with the big body of water out there, even the fish is imported from Malaysia.
Isn't that, I can understand the limited land of not being able to grow land-based foods. But when I heard about the fish being imported, I was like, what? This is crazy.
I guess everything goes to the port and that part of the economy.
Yes, exactly. And they say, the ships leave here because they bring things in, process it, and then it leaves here. So they want the ships to be full in both directions, coming and going. And it's relatively cheap, I guess, to bring the food in from Malaysia or other places. So they just did that.
Okay, I'm going to bring us right back around. So one of the things, both of you, I've heard give wonderful presentations about frailty and how that affects our patients and things like that. We were just talking about obesity. And I think, BobbieJean, I might have asked you this before, again, same as malnourished, you think of that as undernourished, but now it's just mal. With frailty, can you have an obese, frail patient? I mean, is that
Yes, I think you can, because I think it's, measured. There's different ways of measuring frailty now, and one of them is, the burden of disease that you have. Yeah. So obviously, some obese patients are more likely to have metabolic syndromes, diabetes, heart disease, heart failure, those kinds of things that lead to frailty. And likewise, I think that we often think of frail patients as being older patients, right? And only older patients. But increasingly, there's quite a bit of evidence about the younger frail patients and how they actually may do worse than the patients who are older and frail. And it may have some to do with the way we approach them, too, that we don't think of them as being frail or vulnerable.
Yeah.
Where the older patient, just simply labeling somebody as frail, even if you don't do anything about it, quote unquote, like no prehab, nothing changes, it's like labeling somebody at a fall risk. Everybody pays attention a bit differently. It's the Hawthorne effect of unintended, that, I'm going to maybe look out for you a bit more.
Yeah.
But the younger ones tend to be more likely to go under the radar, slip under the radar.
Yeah, I think that's really true. There's something of a lost tribe almost, because the older patient with frailty has the benefit of access to geriatricians. So particularly, it's my experience in the UK, we have a shortage of geriatricians. So in my institution, you can't see a geriatrician until you're over 85. Yeah. Wow. We have a preponderance for the younger medical patient for single organ specialty doctors. And I think these patients with multiple morbidity, and Mike alluded to into one of his talks, Mike Roker, earlier today, when you look at the difference between what is encompassed in a frailty diagnosis or a frailty score versus a list of comorbidities, the extra bit from frailty, whichever of the models you're looking at, is functional impairment. And so I think we all as anaesthetists sometimes meet those patients and you read the comorbidity list and you think, and then you go and see them and they're actually very functionally active. They look great. Yeah. They're still engaging in the community, and you think, actually, I'm not worried. Whereas the converse can sometimes happen, where then it's not a massive long list, but they are very functionally impaired. And frailty brings those two concepts together. And I agree with you that it is increasingly common in particularly the hospital-based population of younger people, because although frailty is rarer in younger people overall, when you look at young people in hospital, they are a self-selecting cohort. And as you say, with obesity, that unfortunately that is associated with increased risk for diabetes, hypertension, then cardiac disease. So lots of things rolled up, and I think they often fall between specialties because what they really need is someone to look at the overall picture. It's difficult.
Can you imagine someday that we will have frailty specialists? Like you mentioned, geriatricians, but not every older patient's frail, not every frail patient's older. So do the geriatricians really just need to focus on an older group, or do we need now a subspecialist even now? Yeah, the frailty specialist.
The high risk. Is there anything like that?
Certainly not in England. I'm not sure. I'm obviously most familiar with our healthcare environment, but I think general physicians 20 years ago existed that looked after these patients with a few comorbidities. And there has been a sort of splitting off of the super subspecialty practice. So cardiologists only see patients with diseases of the heart, respiratory physicians likewise. And you have this group of patients. I'm an intensivist, and so I see them quite often. They come in extremis, end up in intensive care from the emergency department, and then when they've recovered from their multiple organ failure, you're trying to find the right person to look after them, and they're not old enough to be. You sort of feel they need multi-system care, but they're too young to see a geriatrician, and you feel, well, which ward am I going to send them to? They're not a gastro ward, they're not a...
Yeah.
And they need
really
someone that's going to look at the fact that they've ended up on multiple medications, polypharmacy, which is part of the comprehensive geriatric assessment, as you say. But I think even if it's not frailty, multimorbidity and the impact of all of those things, because we know increasingly the more multimorbid you are, you actually have risk factors for other diseases as well, some of which are really obvious, like hypertension and obesity goes along with ischemic heart disease, but some frailty syndromes, perhaps less, or multimorbidity syndromes, less obvious. So almost always in that group of patients, there will be an element of underlying renal disease, and so they're more susceptible to an acute kidney injury perioperatively, and they're more susceptible to CKD. So I really feel, I think that's actually one of the roles of us as perioperative physicians, is to be able to have that bigger picture look, not just looking at what the heart function is, but not just purely the cardiac risk, but what does that mean in a patient who's also got COPD and diabetes and is not eating well and essentially barely leaves the house. The intervention for that patient is quite often, probably the best intervention will be looking at their health behaviours primarily and how all those diseases interact, and trying to nudge the patient on that front, because we know health behaviour determines more of health outcomes than does medical care, slightly disappointingly for those of us that do that for a profession.
Yeah, all that you do. No, that's so true. So a lot of listeners may be thinking, we're taking care of these patients that are higher risk. We're seeing more frailty in forms of obesity and malnutrition and things like that. What are some takeaway points? Because both of you are world-renowned in your spaces. So, you are, and, working in the pre-anesthesia space, like, what are a couple things, like, takeaways that we need to, be thinking about and can do to mitigate some of these risks? Because we know we're not going to be able to change health behaviors.
No, I would disagree with that strongly. So I think we can. I think we should be aiming to change health behaviour. But I think people often get a bit bogged down that prehabilitation, for example, is complex. It's complex intervention, multiple elements. But the basic elements of preparation for surgery are screen for, if you don't look, you won't find, for not just chronic medical conditions, but also nutrition, activity behaviours, and psychological constructs which make it difficult for the patient to engage with medical care. So that's this construct of self-efficacy. Patients with low self-efficacy are patients who tend to not turn up to appointments. They don't comply with taking their medication. When you ask them to give up smoking, they can't manage it. Those are really important factors that we know are modifiable. Actually, that's the great thing about that psychological construct. But what they need is support and engagement in that. And there is a lot of other background from behavioural science that can help us at that point of view. So one of the things I strongly believe is our role as physicians is whenever we meet patients, we should be talking about health behaviour as well as their diseases, not like it's a separate thing to, ignore and carry on treating the end result of the health behaviour, and explaining to them that if they want to live well into old age, that's the thing that they can probably do that will have the biggest impact. And in terms of being a clinician, screening for malnutrition, I think people think malnutrition is really complicated. I used to think that particularly as well, but there's only, most malnutrition screening tools are not complicated. It's how much do you weigh? Are you losing weight? How much are you eating? And anybody can ask that. That's not a highly resource intensive, but my experience is we rarely do.
Yeah. You're not alone. I think there's been quite a bit of studies. I think recall one that something like 4 out of 5 surgeons thought it was important to address nutrition and screen patients, but only 1 out of 100 pre-op processes, pretty robust pre-op processes, had any activity around nutrition screening. And I agree, it's really quite easy to add. 10% of body, you lost 10% of your weight. What's your appetite been like the last 3 weeks?
Yeah.
And I think that increasingly, as I want to do this study, maybe we should collaborate, but can we just get people to add protein powder to their foods? Can we just get them to eat protein, bars that now are, I don't know how they are in the UK. Right, exactly. And just really some more education around good nutrition. I think just as we talked about people with food deserts, right? And growing up, they're thinking that fast food places and, eating out of a can and processed foods is the way to go. I think there's a real ignorance of the population around what healthy eating means. And I agree with you so much about, I think we really need to get patients engaged in their own destinies and understand that at the end of the day, they can have a lot more impact. And I think that when you mentioned about, like patients who don't show up for their appointments, who don't do their medications, I think that is such an important red flag. Often my team I'm working with will be like, oh, the patient's non-compliant. I'm like, have you figured out why
There's always it's the tip of the iceberg and everything underneath.
And they're always bad patients or they're unreliable. I'm like, no, there's probably a ton of barriers that this patient has. And we can probably intervene on a lot of these. It almost feels like we need case management.
Yeah.
But for your preparation for surgery and getting them a checklist, we're big on checklists in medicine, right? And these are the checklists you need to prepare yourself. And I think a lot of it's that psychological preparation and education and some very simple interventions. Sometimes we are looking for the big fancy stuff with,
the silver bullet or something.
And I think especially in the U.S., it's always about, some expensive intervention that you have, as opposed to sometimes it can be much more basic.
Yeah. And I think it's really hugely important to have a multidisciplinary team to facilitate that. So we have a dietitian, our own dietitian. It's not that the surgical teams don't have their dietitians too, but we found that about 30% in addition to, we'll know to them, were at risk of malnutrition. They have a really important role being a clinic with the education. We're hoping to develop a centre for healthy living where there's going to be a kitchen, so some basic cooking instruction. What constitutes a healthy diet. People's health literacy is much poorer than we believe. Even the literature we produce, we've just rewritten all of ours. We have a surgery school, which is a sort of education intervention before surgery for patients and their relatives, carers, friends. I only read it recently because I've been doing something else. I used Microsoft Word has a reading age thing in it. The reading age was 17. Well, the average reading age in the UK is 9. So, I think we need to provide information for patients that is understandable, that they feel is relevant to them. And we then need to support them in some of those changes. And, we all know this behavioural change is not easy. But I think if you speak to public health scientists and doctors who spend their time trying to get people to stop smoking because in 50 years' time you're going to get lung cancer, we have the real advantage that something's going to happen and pretty soon.
Yes.
And they will say, the immediacy is a really good trigger for making a change. We definitely see that in some patients. And the data from the Manchester team in cancer patients, so they've just implemented a sort of program like this with supportive nutritional psychology and some exercise support, that at a year, patients' frailty scores were less. There are very few interventions that, have that impact a year post-op. So less improved disability-free survival, improved one-year mortality. But importantly, it's about health span, not lifespan.
Yes.
Better quality of life in the survivors. And they were still exercising, which is just fantastic. If we can achieve that.
Triggered a thought that I wanted to make sure I, articulate here if I can. When you said about there's a target or a moment, right? It's like, I used to, try to give my smoking cessation lectures or, like motivating speeches to patients about, stopping smoking and long term and all this. Now I'm like, your surgery is in 3 weeks. If you stop smoking today, you can lower your risk of surgical side infections. You can decrease. You don't have to stop for life. Like I used to want them to stop forever.
Yeah.
And sometimes, especially that, new students or residents, I'm like, what do you mean? You're tired of almost endorsing that it's okay to restart smoking. I'm like, no, they have to get their heads around something.
Yeah.
And most people can do something for 2 weeks or 3 weeks. They don't have to sit there today and think, I'm never going to have another cigarette. Yeah. That's too much for them to take on. And then, they're anxious. I find that it's so much more successful. And then I find that they are more likely to then not.
Yeah. What is it, 21 days, right? That is, it starts the habit.
Got to get them to stop first.
Yeah.
So bite off the chunks in little pieces.
Yeah.
Just like I tell my diabetics, I want you to start walking 15 minutes a day. 15 minutes is all.
I say walk to the mailbox.
Right.
Go get your mail.
That's right.
And start by doing something like that.
Right. In 2 days, you're going to go 20 minutes.
Yeah.
You're going to do 20 minutes for 2 days.
Yeah.
Okay. We're just going to do baby steps. And so again, I think try not to do too much.
Yeah.
Try not to set your goals so lofty or so beyond where the patient's capable of going.
Yeah.
Start with some basic stuff.
That's fantastic. I would love to continue this conversation, and hopefully next time we're together, we can, because I think it is really important. This is very useful because people don't think that they can, that this is not achievable. As clinicians, we don't think that this is achievable. And I think both of you have shown that it really, truly is.
You've got to put the patient at the centre for what you do. And with these patients we've talked about with multiple comorbidities, the list of things they should be doing might be completely overwhelming. They're smoking, they're drinking a bit much, their diet's not good, they're not doing much exercise. And that's why you have to engage them and say, which of these things do you think you feel like you want to address now? Which could you address? These are the ones that can have a big impact. And exactly as you said, if you say to them, you're more likely to get home, to find out what's important to them.
Yeah.
Why are you having surgery? Fascinating, really good opening question.
Isn't it really? Exactly. And I think even in highlighting that, you're putting yourself through this. You're going to have this recovery that, if you're willing to do that, then let's be willing. Let's work on some other things you're willing to do to add to the success of that. Because it's tough having surgery.
Absolutely. All right. So really quick plug, Denny. You are going to be the chair of the perioperative medicine track in 2 years in Marrakesh.
Oh, yes. I'm very excited about that. We've got a separate perioperative medicine track again in 2 years in Marrakesh. We've got a great committee, including BobbieJean here, if you're pleased to hear, from around the world. So the aim is to get input from around the world. And it's a slightly smaller conference next year, so we're not sure exactly how many days of each track we'll have. But there will be a mixture of lectures, some workshops and some case-based learning discussions around exactly these topics, and particularly the implementing. I think other clinicians who haven't worked in the space feel a bit overwhelmed by the impossibility of the mountain. And I think actually there's some really easy things you can do without any extra resource. And just nudging a small group of patients at the high-risk end will have a big impact. So really excited about that.
I'm so excited for this with you guys at the helm. I know that all the topics, it is going to be a lot of really great information.
Well, we hope to get abstracts too, right? So I hope there's a plug. Please submit perioperative projects that you're doing, the 2-year lead time. So you can start a project and
there's a very big prize as well if you win it, $1,000 or something if you win it. Yeah,
and it's in Marrakesh, Morocco.
Well, very nice. I can't be. It's not terrible. All right, guys. Well, thank you so much. Enjoy the rest of your day and safe travels back home.
Thank you.
Yes. And thanks for listening to Top Med Talk. You can always find us at TopMedTalk.com. You can find us on your favorite social media platform, LinkedIn, Facebook, X. We are there. And check us out on YouTube. We have a lot of people going to YouTube right now. And so subscribe. Give us a little thumbs up. We always appreciate that. And thanks so much for listening. Cheers.
Top Med Talk. Thanks for downloading Top Med Talk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, Top Med Talk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.